Hello, everyone. This is Dominica Murphy. I'm the Community Director of SurroundHealth. I just wanted to extend a very warm welcome to all of you for attending today's webinar, Skills for Moving from Mission Impossible to Mission Accomplished. Just wanted to take a minute to thank our sponsor for today's webinar, the National Communication Association. I encourage all of you to visit their website, listed right there, to learn more about the organization and membership opportunities. Just a couple of things to keep in mind. We will be taking questions at the end of the webinar. So if a question comes up for the speaker, please type it into the questions section in your webinar control panel, and we will get to them at the end. We are also tweeting during the webinar, so if you are on Twitter, we hope you join us using the hashtag #SHWebinar. We are recording this webinar, and it is being archived, so you will be able to access it after this webinar. We have also been pre-approved for 1 CHES and 1 RD credit. And to receive your certificate, please be sure to complete the feedback survey you will receive in a follow-up email from us. We have a wonderful webinar planned for you today with Dr. Jim Dudl from Kaiser Permanente's Care Management Institute. Jim is from near Cleveland, Ohio, attended the University of Michigan for the undergrad and medical school. He interned at Philadelphia General, did his residency back at the Cleveland VA and Case Western Reserve, and endocrine fellowship at the University of Washington. After joining Kaiser Permanente, he has been a clinician as chair of Diabetes Committee in San Diego, the co-chair at Southern California Permanente Medical Group, and presently as the diabetes lead at the Care Management Institute of Kaiser. He has been a surfer, traveler, and is especially fond of his time getting 150 minutes per week of exercise with his Labradoodle dog and his grandchildren. I would now like to turn it over to Dr. Dudl.
Oh, thanks. That's a great introduction. Welcome, everybody. Really delighted to have you here. We are going to do a couple of things, and the first is to ask you to do a quick poll so I can see kind of where you're starting from, and then we're going to ask these same questions at the end. You're going to hear a lot about repetition. So let me ask you if you can look at the dashboard. That's that rectangle box on the right-hand side of your screen. And if you don't see one, there should be a little red-orange arrow on the top left-hand that if you press it, it should appear. And you should go down about halfway down and see a box called Questions. And just click on it and open it up. And then, so the first question I'm going to have for you, when discussing a new treatment, do you proactively ask the patient about barriers? And the choices are yes is 1, no 2, or doesn't apply would be 3. So take a second to go ahead and answer that question. When discussing a new treatment, do you ask the patients about barriers? Yes 1, no 2, doesn't apply 3. And it takes a couple of seconds for this to evolve, so we'll just go with that. While it's evolving, let me also ask you, everybody who can, if you're not driving, take out a pen and pencil. And I'm going to ask you, or pen or paper rather, and I'm going to ask you while you're going through this talk, if you hear one small piece of anything that you want to do, I want you to write it down, because we're going to, again, ask you in the questions to type that in at the end. What we're going to present is a virtually overwhelming amount of material. Nobody is going to be able to do it all. But never underestimate the power of the very first small step. And if you write one thing down and do it, it's amazing what else can happen. So let's take a quick look at the poll results. And 57%, that's fantastic. So 60% of you already are asking for barriers. And for some of you, you may be then ready for the more advanced parts of this talk. And can we go on to the next question? About 30% doesn't apply, so there are some non-clinicians here. There should be a second question, and it is, how many routinely ask at the end of a visit, what are you going to do? Yes, no, doesn't apply, same question. So if you'll take a moment to fill that out. And you're going to hear a fair amount about these questions and how they evolved. The whole idea, as you'll hear, is this is to be extraordinarily simple. And so the questions are very simple, but the background is quite robust and complex, and most of it evidence-based. So I presume the question is being asked and being recorded. So we'll just wait for a second for the results. Here we are. That was quick. So, we have a really very advanced audience. So about half of the audience already asks what you are going to do. So again, for you, there may be some more advanced next steps to take than these two questions, and there's plenty of other stuff around that we're going to discuss. And of course, if you have suggestions, by the way, as we go, it would be fine for me to, for us to hear what they are, and if you have suggestions for the group that, having heard the talk, I always welcome those. So let's go ahead right on now to the talk. And let me just say, for years I've heard practitioners say, I tell them, and I tell them, but they just don't do what I say. It's not just difficult to get them to act, it's impossible. So when I hear that, I think there's only one thing to do. That's right. It's mission impossible. Let me see if there we go. Okay. I've got to be sure we've got the controls working here. So the bottom line is it isn't impossible, but it is tricky, and taking a few small steps is the best way to get started. So let's get right on to the agenda. We're going to cover what's the problem, what hasn't worked, what works, and of course that all starts with setting a goal and treatment and deciding how to intensify the treatment, and by considering something called the TIAs, and by that I'm not meaning small strokes, but we'll cover that. And then remove the barriers to action using something called ask, educate, ask. It's a very simple template for the half of you that don't already use something like that. And a case study to have a little fun and see how it works. So let's go on. So what's the problem? Well, literacy is a big part of the problem. And last month you heard a really excellent lecture, I thought, on core literacy, conveying how to make information clear and actionable. And that builds then for this talk, which engage literacy using what you learned. Engage the person. Agree upon goals and treatments, and get action to achieve those goals. This is going to focus a lot on interpersonal skills and behavioral language. Yet to come is influential literacy, advocacy, and policy, and I'll leave that to your leaders to plan. So what hasn't worked well enough? Well, practitioners making unilateral decisions on setting goals, deciding treatments, and then telling people what to do. And we'll cover why that doesn't work in just a moment. How to start this? Well, we're going to assume for a moment that motivational interviewing was done by the doctor while establishing a mutually agreed upon goal and treatment. Now, you're going to notice anything in bold, I'm going to tell you flat out, we'll come back. I'm going to ask you questions as we go. And the material written in bold are the answers to the questions. Now, why am I doing that? Well, I have learned, and this lecture will tell you, that most of the stuff you hear you can't remember right away. So if you highlight it as you go, there is a higher chance that you will recall it later on. And there may be only a few things that you can get across. And so bold is my way of beginning to do that. And we're going to assume that at least 2 treatments are possible, and the provider is going to consider treatment intensification schemes. And why is that? What evidence is there that treatment intensification is something we ought to focus on? Well, this is one of the important slides of evidence, and this was from a very large study, 500,000 patients with an equal number of controls, where medications were used to intensify for high blood pressure, hypertension, diabetes, sugar, and high cholesterol. And a year later, after they intensified in one group and didn't intensify in the other, they looked at those who reached control at target. Blood pressure was improved to target 14% more in those that were intensified. A1C glucose measured 29%, and high cholesterol 51% of the time. All 3 of those were statistically significant, 0.05. So treatment intensification works even on a large scale. The neat thing is that it also applies to lifestyle treatments, which are equally important in the long run, so we'll come to that. Now, the next slide is let's break down what treatment intensification is dependent upon. How do you treatment intensify? Yeah, go intensify. Well, what does that really mean? Well, there really are 3 things that you can influence. Titration, initiation, or adherence, and that's why the abbreviation of TIA. And this is the evidence behind the fact that TIAS, with one other addition, is the whole universe of choices, and these choices apply to virtually everything you're trying to get people to do. And this is a particular study, again, done in diabetic patients, 122,000, who were above target 7. What they did is they said, well, let's review the charts and see what were the things that they should have done that didn't happen that led to this problem. And the very first thing they found was 30% of the time, about a third, they either needed to titrate or initiate a medication. So if you're looking at a chart like that, you may need to get, you either have the authority to do it by protocol or get someone to write for it. But this next one is really interesting. Adherence. About a quarter, a little under a quarter, 23% were poor adherence. Now, that's a figure that was done in fairly short period of time. The issues are much higher with longer term in chronic medications such as statins. At 1 year, there was 50% non-adherence. And at 2 years, there was 75% non-adherence in one of the studies. So adherence is a big deal, and we'll come to that again in a second. And the last thing is starting strong. 50% of the time, they started with a medication not strong enough to hit target anyway. Now, if you're using insulin, you can't start with 100 units in everybody, even though some will get there. So that's understandable. But for things like statins, where there is no problem with strength, you want to start with the strongest dose you can, because that's the biggest barrier, is starting with too low a dose. The strongest treatment that's safe. Now, let me just mention, now this can be applied to lifestyle, and let's just use exercise for an example. You could titrate. Somebody is walking, half a mile, titrate it up. You can initiate doing upper trunk along with lower trunk. You could get them to adhere if they don't go to the gym every day. And you can start with the most exercise that they're used to doing. So you start at the top you possibly can. So you can see this is a template for you to use and say, well, if I want to intensify, which we know works, these are the ways we can do it. And our nurses have been doing this in our clinic, and it's become part of their habit. And, of course, that abbreviates the TIAs. So let's move on and talk about the barriers. So now that we know what the TIAs are, what are the barriers to the TIAs? And we break them into 2 to begin with. The first is complex technological barriers. And an example I use is commonly we give people this fairly complex regimen of medication. We want you to add up your sugars the last 3 days, divide by 3, and then come up with a addition that you should make every 2 days to your insulin and go home and do that. You know, virtually those things are impossible for people to do. Now, the literature on technological barriers isn't really in medical literature, but one of the best examples, I'm only going to quote one, is Siegel, reference below, Insanely Simple, the story of Steve Jobs. What he did is he said the basic principle behind everything I do is to make it so simple that the average person can do it. And I will only ask you to think of the Apple products and how you see them compared to others to see if that works for you. But let's focus now on behavioral barriers, because those are the ones that you can deal with right away. And here we need to focus on motivation, barrier identification, self-solutions. This can take 3 to 20 contacts by our data that we have been collecting. So it's really significant. Now let's move on to adherence barriers, and I'm going to focus on adherence because anybody on this line can discuss adherence with any patient. If a doctor has already ordered or given instructions to a patient to do something, you don't need a high license to say, are you doing what the doctor said? And if not, why not? So anybody can deal with any of these at any time, and as you've seen, adherence turns out to be a really major problem. And we break it into 3 categories: patient-related, and here we see, and I'm going to give you the top 3. Notice they're in bold, so these are going to come back. We're going to have a question that these will be the answers to: forgetfulness, lack of knowledge, and value of therapy. But there are many others: cultural, ethnic, denial, financial, health literacy, social support. So there's a lot of patient-related. Medication-related, complex regimens we've covered already, and either side effects or fear of them. Multiple medications, length of therapy are problems, and provider-related. Mistrust is you've got to gain the patient's trust. If you don't have the patient's trust, how can they move forward if they don't trust what you say? Poor communication, cultural disparity, lack of feedback, focusing on the negative aspects of treatment are all big deals. Now, let me also say, now, what I want you to notice, and then, well, what I want you to notice first is that there's so many of them, it would be really difficult for you to guess which one or ones are important. And then let me give you a case of an example that taught me a lot. I was talking to a gentleman who I thought ought to start insulin. I had just read Bill Polanski's list of the 10 common barriers, and I literally went through them one at a time with reasons why they shouldn't apply to him. At the end, he stopped me and he said, "Doctor, that's wonderful. Thank you so much, but you don't understand." By the way, when you hear you don't understand, you know you're getting somewhere, and it's important. He said, "My wife just was diagnosed as Alzheimer's. She wanders around, could wander out of the house at night, and I can't afford to get confused because of insulin." Now let me ask you, what's the chances that you or I could have figured that barrier out? And I mean, you know, the answer is just about 0. We'll never figure that out. And therefore, and I'm going to tell you one more figure, 40% of the barriers individuals have are not in the top 200 barriers. So the bottom line is guessing what the barriers are is likely to not be fruitful. Luckily, we have a wonderful source, and that is the patient. We merely have to ask them. And then the last thing, there are 3 barriers per person. So when you get one out, you're not home free yet. On occasion, not all the time. So we'll cover both examples. Okay, so improve the barrier busting. Let's get on to that. You will not likely get your treatment intensification unless you remove your barrier, overcome your problem of telling them what to do. Now, half of you have already overcome that. That's great. this is just reinforcing, but for the others, this is a very, very important step. So we go on to a way to do that. And for those who already know this, great, but there's so many little steps in here. Maybe there's one new one for everybody. And the first one is ask about the barriers. And the first question, and this is a script which you can vary, or for you who are already doing it, maybe it contains a little something that's new. In order to start doing TIA, whatever it is, regularly tomorrow, what problems, questions, or concerns do you need to deal with now? Now let's dissect this for a second. First of all, the very first thing you do is ask and listen, and you're learning. The second thing is you are focusing very tightly on the single action you want them to take, and you are asking them to raise their barriers. So it couldn't be more specific or targeted. So it's a very simple question, but it should get people right to where you want them. Then once they tell you what one of their barriers are, you can educate around the point. The point here isn't really for you to solve their problem. The point is for you to model problem-solving behavior. So you're going to say something like, well, you know, you could take a pill box to organize your pills or something like that. But then the next thing is that's just a model for them to use, because the very next question is, but I'm curious, what would work for you? What did you just do with that statement? You just asked them to solve their own problem. You did it very nicely. You gave them a little hint about one thing or another, but you really did. You are teaching the problem-solving ability. And what will you do to make that happen? Now, why is this question? This question can't be passed up, by the way. 60% of people in one survey did not act not because they didn't believe what they had to do. They were already convinced they should do it, but they didn't have an action plan. So it just didn't happen. They never got around to it. Remember that, round to it. So you're going to make sure they get around to it. What else? Because there are 3 barriers per person. And then this last question, which I'm glad to see half of you already do, but for the rest that don't, what will you do now? And this is called Teach Back. Now, what is Teach Back? Well, Dean Schlesinger of UCSF gave a lecture to a national webinar, and at the end he said, you know, after the whole hour, but there's only one, if I could only get you to do one thing, it's ask this question. He said, but be careful. Leave 10 more minutes at the end. Don't do it when you're 20 minutes behind. And be ready to have a bruised ego. And I thought, well, if he's going to ask me to do that, and he's the expert on literacy and all of this stuff, I'm going to do it. So I did it. And I must admit, he was so right. After a nice 15-minute visit, I asked my patient to repeat back. He could not repeat back 80% of what I had said. And I was being particularly careful with eye contact, using simple words, because I knew I was going to ask him this question. And he missed the key action point that I wanted him to do. Well, that probably was the best thing that ever happened to me, because then I threw out and I kept rechanging my plans until when I asked this question, I get the answer of the action, or at least their opinion of the action that I'm after. So where is the evidence that this makes a difference? Well, Dean did a test, and he had, just a small study, about 40 diabetic patients came in to see his nurses. And in a group of them, they asked them to teach back what they said, and the others, they didn't. And they learned 2 things. First of all, in those they assessed, they asked them to teach back. And guess what percent actually taught back to the nurse what they asked? And it turns out to be about 30%. Then what he did is he asked them to keep repeating the action step they wanted them to take until they got it right. Another 30% got it with 1 repetition, the second speak. and the rest required 3 or more to get it, but they kept repeating until they got it. Now look at the difference in A1C on return, 55% versus 92%. They just merely walked out knowing what to do. They didn't tell them anything new to do, just made sure they knew what to do. This fits with a beautiful VA study that showed that 80% of people walking out of the exam room did not know what the action was that they were to do. So maybe, for those who aren't doing this already, this is something you might consider adding in. And it can be done anywhere, and one of the polite things to do is say, so I can write it down correctly. What are you going to do? Because often you're repeating this 2 minutes after you told them, and it's a little embarrassing to them when and to you to even ask the question. So let's go ahead and do an example, and this is going to be the first barrier-busting question. In order to start taking your medicine regularly tomorrow, what problems, questions, or concerns do you need to deal with now? And let's say the patient says, forgetfulness. I can't remember to take my pills. Now, you as educated clinicians, I'm impressed from your poll that a lot of you know how to do this, probably know how to educate their patients. So I'm going to ask you now to go back to your dashboard, into the questions, and type in an answer. What would you do to educate your patients on, I can't remember to take my pills? I'm going to give you just 15, 20 seconds to get started, and we'll read a couple of the answers. Remember, you click on that arrow to pull up the dashboard if it's closed, and then go down to questions. And set an alarm. Set an alarm on the phone. Wow, this is great. Oh, we're getting a lot of good answers. Computer record. This is going so fast. I have a hard time reading them. Pillbox. Yeah, great. Fantastic. Write down. Bubble packs. Yeah, bubble packs. Mirror. Pillbox. Reminder on the bedroom door. Great. Okay. Thank you. I'm going to go on back because you've actually hit on many of the things. And let's just see what this doctor said to do. And what they said is some find it helpful to do it something you do every day, like drinking coffee, brushing teeth, eating. And by the way, all of your suggestions were good. Those were really good suggestions. And if you made any of them, that would be appropriate, especially if you ask following, what would work for you? And I'm not going to go, well, had a really great example of a woman where I suggested she put it with her toothbrush in the morning, and she told me she couldn't do it because she was babysitting her granddaughter, 3-year-old, and that wouldn't work. But what would work for her was to put it with her crossword puzzle that she does every day. So very good answers. Thank you very much. Appreciate your participation. And then what else, and what will you do now, which we will go through again later. I am going to go, I think we're going to go right now to the skit, the case study. And the reason is I think that we have more information in that that's a little more fun to do. So let's go ahead and practice. And I'm going to talk to you about my great friend Dave, who helps me through this lecture all the time. Dave Molidas. He's a 50-year-old African-American who was just found to have a fasting glucose of 120 on 2 occasions, which the physician appropriately then used to diagnose prediabetes, gave him a prescription for metformin. His weight's 220, height's 5'4", blood pressure's 142/80, cholesterol 200, usual numbers for a person like that. And he has been referred to you for counseling. Now, we're going to ask the Surround folks who are going to do a little skit for you. And let's listen to how DM used Ask, Educate, Ask. Now, they use with Ask, Educate, Ask. Go ahead.
Hi, I'm Nurse Wilhelmina Listen, but feel free to call me Will Listen. I'm pleased to meet you. By the way, what would you prefer I call you?
Well, my name is Dave Nalitis, but you can feel free to call me DM.
Thanks, DM. Now I'm looking over the summary Dr. Overbusy sent to me when he referred you to me, and it says that you know you have prediabetes, and it looks like your mother had diabetes and didn't take care of her sugar, developed kidney failure, and ended up on dialysis. Dr. Overbusy writes here that on a scale of 10 for action, you are 8 out of 10 ready to do what you can do to prevent diabetes in yourself. Is that about right?
Yeah.
Great. And your doctor also said she talked about 2 treatments to prevent diabetes. One that she discussed with you was losing about 15 pounds and exercising half an hour 5 days a week. Or the other option was taking a pill called metformin at supper, the side effects of which Dr. Overbusy covered with you. She advised you to start metformin because you've had difficulty losing weight in the past. She gave you a prescription and referred you to me for follow-up, and that's where we are today to get started on it. Did you get started on the metformin?
Well, I tried it for a couple of days, but honestly, I kept forgetting to take it, so I just stopped.
Okay, let's hold the skit right here. And let me ask you, what did we discuss that the doctor did not do with AEA? You can type it in, but we need to move along, so I'm not going to wait for all the type-ins. But thinking back on all the stuff we've covered, especially that was in bold, what did she not do that we suggested you do, and might have, and someone asked, they said, did not cover the barriers. Explore barriers. Yes, great, terrific. Didn't cover the treatment plan. Wonderful. You're just really right on. Well, first of all, she didn't see if the patient had mutually agreed to the treatment plan. She unilaterally said, yeah, trouble with weight loss, so I'm just going to give you the metformin. And then she didn't ask about, would there be any problem with you taking a pill at bedtime? So let's see how Wilhelmina did with this. So back to you, Will.
Oh my, I'm curious. In order for you to start taking metformin regularly tomorrow, what problems, questions, or concerns do you think you need to deal with?
Well, for one thing, I'm not sure metformin is really the right treatment for prediabetes. I saw it on Dr. Oz. It's for full-blown diabetes. Now, does that mean I have diabetes, not prediabetes?
That's a great question. At times, there are 2 uses for one drug. Like aspirin is used to help headaches, but it also is taken to prevent heart attacks. What your doctor is suggesting you do is take a medication that's recommended for prediabetes by the American Diabetes Association and the U.S. government's National Diabetes Education Program. For some people, that's enough to know that those are the recommendations. But I'm curious, what would work for you? Who do you trust?
I can tell you the only doctor I would trust is my brother's doctor, Dr. Friend. He's been at it for 20 years. He's been like a family member and a deacon at my church. If he said it, I'll believe it.
Okay, let's pause again. What did the doctor miss? And you can type in again, and I will read the ones I can get to. But let me also get working on this. First of all, he had certainly mistrust. Yeah, there you're coming along with him very, very clearly. And the patient had also a lack of knowledge. He said that Dr. Oz was right, but he didn't cover prediabetes. And Willa did a great job explaining the dual purpose, and he believed that. That was good enough, but the lack of trust. So what happened, though, also with somebody got lack of knowledge there. That's great. So what happened when the nurse assured him the U.S. government and the ADA both supported the doctor? The patient doesn't trust either the government or the ADA. Now, is that rare? Well, the answer is no. People come come, with different things that they've heard from different groups, and they may not. What Willa did was really fantastic. She asked him who he would trust. Who would he trust? The African-American deacon. Wow. So she did find somebody he would trust. So let's go back now to Willa. Why don't you pick up and go from here?
I have a thought. Would it be okay with you if I got Dr. Busy's permission to send your brother's doctor a note and ask his opinion, and I'll call you with what he says?
Sure, that'd be great. I'd feel a lot better if he agrees.
Okay, so if he agrees, it's a good next step for you. What will you do now to make that taking metformin happen? What else was getting in the way?
I still have the prescription at home, but like I said, I keep forgetting to take it. I'm just not used to taking a pill at supper time.
Putting medications where they will, at a place that they'll automatically remind you, works for some, like by a coffee cup. But I'm curious, what would work for you?
I guess I could put the pills next to my coffee cup that I always have at supper, and I could take it with the first sip. That's something I always do.
Excellent idea. Now, so I can write it down. What are you going to do?
I'm going to wait for your call about what my brother's doctor said about the pill.
Okay, great. And what else?
Not sure.
Pills and the coffee cup?
Right, okay. I will put the pills next to where my coffee cup is at dinner and start taking them if the deacon agrees.
Great. And I'll call you with your brother's doctor, and I'll write these down on the after visit summary, and you can use it to remind you to look at them when you get home. Can I see you back in 3 weeks? Almost always new problems come up, and I want to help you deal with anything that gets in your way. Feel free to call me or cancel if all is going well.
Okay, sure.
Okay, let's stop again. Now, several points we could make that just occurred. First, we'll address the need for a trusted source. She listened and got what the patient would move to action. She thought outside the box. Sometimes the solutions aren't ours. They belong to the person's culture, and we have to move to wherever they think. Secondly, she uncovered the other barrier for getting to take the pill and suggested a solution, but she listened to his and followed it. And so she helped the problem-solving skill that she was trying to instill. Thirdly, she asked him to repeat back the second step. Note that even though she mentioned it just a few minutes before, he forgot it that quickly. It may not have gotten into his action plan. So she wrote it down and handed it to him to take home as an insurance summary. And lastly, she scheduled a follow-up visit. Most of the time, patients uncover barriers they didn't know they had at the time of the visit. So this opt-out strategy, come in unless you don't need it, sets up a routine. It's a lot better than call me if problems. Now, let's go ahead and hear how the return visit went.
Dan, good to see you back. You said on the phone you started the metformin, but then you stopped.
Yeah, thanks for getting that second opinion. That really made me feel great about it. But I tell you what, I really got bad diarrhea. Dr. Overbusy did try everything to get around it, but nothing worked, so I really had to stop.
Okay, so your doctor said she also talked to you about another treatment, which was losing about 15 pounds and exercising half an hour, 5 days a week, but didn't advise it because you had difficulty losing weight before.
Right. I have a terrible time losing weight. I did lose some weight on Weight Watchers, but dropped out midway. I just couldn't do it.
May I explore, can we talk about the possibility again? I know that Weight Watchers just started an online program specifically for men.
Sure, okay.
So in order to start Weight Watchers this coming week, what problems, questions, or concerns do you think you need to deal with now?
Well, first of all, I just don't think I could do it alone. Last time I started, I have no willpower. I caved into my appetite.
That must have been difficult. For some people, what works is to plan ahead, to include what some might say are emergency snacks, healthy snacks, to have them available, and also have a plan to contact a program director if you feel like you're close to dropping out. But I'm curious, what could work for you?
Well, those are good ideas, but I just remembered my best friend, Sam has been after me to join a weight loss program, kind of like Weight Watchers, with him. So I guess I could always call him if I get cravings, and he would understand and help, and I could do the same for him.
Great idea. You're so good at problem solving. So what will you do now to make that happen?
I'll give Sam a call.
Great. When?
Well, tonight if I get a chance.
How about calling him from the waiting room right now?
Okay. I think he's working, but I can text him.
Great, even better. Great work, and I'll write it down for you.
Okay, let's stop here again. By the way, there was a question about whether we violated HIPAA if we send something to the brother's doctor. Of course, the patient is sitting right there, so you're getting the patient's permission to do that, and therefore it's not violating his HIPAA rights. If you did it without him agreeing, of course it would be, and you would be quite correct on that. Anyway, what happened? Well, you could type in some thoughts also, but let me just move ahead because we don't want to run out of time. DM will listen about the snack, and the call was a great suggestion, but he substituted his own solution, and she will listened and succeeded in getting him to problem solve, congratulated him, reinforced the small step, good habit, all those good things. Notice he moved him to action right away. How about the waiting room? Oh, well, no, text message. Well, text message is pretty good nowadays. So actually, she will and has worked him to taught him problem identification, self-solution, and moving to action. So it's time to stop the skit. I don't know if there is a hand, but anybody who wants to give a high five by slapping the hand on the left-hand side of the dashboard to thank our folks, please do that because they did a great job and we appreciate it. So let's go back now to the slides. And this is, we're going to be talking about just a summary here, and then we're going to take questions. Assuming mutually agreed upon goals, what is your role? Well, as we've talked about, treatment intensification would be one of the things you could really focus on, and you can always deal with adherence. Inpatient motivation, ask, educate, ask is your action plan to implement the TIA, and we need that action plan. The first question, in order to start tomorrow, uncovers barriers, including lack of motivation, if that was missed. How you make that happen is the patient setting an action plan. What else gets all the barriers out, and what are you going to do? Make sure that you got the message correct and got through. Remember, AEA works in other situations too. So now what I'd like to do is just repeat that poll, and then we'll take questions. So if you bring the poll out. And you're used to the poll by now. So the first question is discussing a new treatment. Do you proactively ask patients, or will you proactively ask patients for barriers, having heard this lecture? And then either do or will start. It is yes, other no, and doesn't apply. Please go ahead and answer it. And while you're doing that, taking a moment to just think about, is there any step or steps or action that you might take, even a small one, that you have heard, and we'll ask for that after the end of the questions. Results are in 81%, so I think there was a significant increase in, as I recall, it was around 50%, perhaps one of the, you could remember better. I didn't write it down, but I'm quite sure that's an increase. Here we go to the next question, please. And how many routinely ask or will begin to ask, what are you going to do? Yes would be no, it doesn't apply. Well, I'm certainly very impressed with this audience. It's sort of funny when you can't see the people you're talking to, but both the polling questions and the rapid, correct answers that you gave to the questions was really amazing. Many of the audiences I've talked to, you certainly are responding at the top of the knowledge of the pre-lecture. So you should be congratulated. And the results are in. And how many routinely ask at the end, what are you going, or will ask, 81%. So again, about a 30% increase. So thank you. That was very, very helpful. I really appreciate the extra time it takes to do these questions, but it is important for us to know whether or not we really are in the right ballpark of giving you some thoughts that might be helpful. And of course, now it's time to questions. So let me turn it back over to the moderators and fire away.
Great. Thank you so much, Dr. Dudl. If there are any questions from anyone, please type them into the questions section. We did get a couple throughout, so I will start, Dr. Dudl. Can this approach be used in inpatient, or is it more appropriate in outpatient settings?
The actual interesting thing about Ask, Educate, Ask is it can be used anywhere with anyone you are trying to move in an action. And therefore, inpatient would be absolutely appropriate. You know, I have to tell you this because it's just funny. It's so versatile. So I was talking to my wife a couple of weeks ago. I said, honey, you know, remember that trip that I wanted to take to Hawaii in 2 months? What problems, questions, or concerns do you have before booking that trip? And she looked at me and laughed. She says, I know exactly what you're doing because I heard your lecture. But the issue is you can use it any place, anytime you're trying to move someone to action.
Great. Thank you very much, Dr. Dudl. There are some questions about the slides. I just want to reiterate, absolutely, this is being recorded, and we will also be providing slides at the end of the presentation. So the next question for you, Dr. Dudl, is can this also be used outside of diabetes?
Oh, absolutely. I have used it in any number of, certainly in all chronic diseases, but realistically, an awful lot of the time we practitioners spend with patients is working them toward a solution of action. And I would strongly encourage you to use it wherever you find you need it. The issue is once you do that in a number of diseases, you're going to start finding out that it applies all over the place. So yeah, it's baby steps. You take another step and you'll find another open door.
Thank you. Are there any situations where this approach does not work?
Oh, sure. Lots of situations. You know, if you're dealing with a hostile, a person who doesn't want, you know, they're not motivated, or they don't want to change, they don't want to talk, they just won't answer the questions. The nice thing is it's polite, and of course should be polite and should be permissive and should be inclusive. So when you hit a door of no, I don't have anything, I don't have anything to say, no, I'm not interested, I don't want to talk to you, or they hang up, you kind of say, well, let's move back to this readiness to thing, and that line that they use in behavioral. I realize that right now this isn't appropriate for you. If in the future it seems like you might be interested in this, could you call? I'd be available. Love to talk with you. So that kind of thing.
Okay, great. From those individuals who have taken your workshop, Dr. Dudl, and have used this approach, what are some of the barriers that they are seeing, and maybe some solutions for those barriers?
I honestly think that, well, I'm not quite sure which direction the question goes. I'm going to answer it one way, and if I miss it, ask another, because there's lots of possible ways. But one of the things is it doesn't get implemented. And if it doesn't get implemented, it's partly because they haven't taken the time to do the steps and then change their behavior. And I can also tell you that when we did one talk like this, and virtually, there's so much here, it's virtually impossible to do it. And what we did then is we broke it down into 4 one-month steps. The first step is go back and get somebody engaged. Each question, you take break it into 4 questions, and just say, go and do 1 question and come back in a month and tell us what happened. And that really worked, because then people could work on each section separately, and by the end of the 4 months, they really incorporated it. I don't know if that's the direction of the question, and if I missed it, please type it again.
Okay, thank you, Dr. Dudl. Would you say that this method is also effective in phone follow-ups?
Oh, absolutely, unequivocally. This was, it was helpful. You know, if you don't listen to the people doing the work, you're really crazy. A good chunk of this, the credit really goes to my nurses who taught me all of this stuff. And they did phone treatment of starting statins and ACEs over the phone. We wrote letters to folks and tried to get them in to their primary doc or whatever. We got a 10% response. Over the phone, they got 30% of people on medication. It's very effective on the phone.
Great. Thank you, Dr. Dudl. Are there any recommendations that you have when working with elderly patients?
Well, you know, a number of things. The first question is now the target, and you know, in the ADA and American Hypertension Societies that are due, and NCEP or the cholesterol ATP groups are all saying that we have to relax our targets after 65. So number 1, you have to relax your target. Number 2, minimize what you're trying to get done. This is that technologically complex thing. You boil it down to 1 simple step that they can do, or they can assist. And of course, that's the other thing, social support, not uncommonly in the elderly. A second person's help is virtually mandatory, or things don't get done.
Okay, great. And would you say this is similar to pediatric patients when they may not be able to control the barriers?
Absolutely. They'll define the barrier for you. You notice that Willa will listen, got a solution of going to a minister or a preacher who is outside of the medical care system. So if you're listening to a kid and he comes up with a solution that could only be solved at school or something else, it's your job to figure out how to get that done. Absolutely.
Thank you. Have you ever given a list of barriers to patients for them to be able to jog their own thoughts about their barriers?
Yes. In general, I found it unsuccessful, and so that's valuable experience, I guess. The reason being that the real power is role modeling for them. You know, here's one thing to do, but what will work for you? And rather than giving them a list and probing down 3 deep. There's one other thing I didn't mention, and that is root cause. Commonly people say, well, I forget to take my pills. And then, well, what else? Well, you know, I'm not really sure I need them. And then what else? Well, You know, my religion doesn't believe in it, and I have a fear. You know, when I was young, I took a pill and I had this thing, and I almost died. So I'm fearful. So sometimes you get the root cause by probing deeper. I'm more for probing than I am for giving a list.
Okay, thank you, Dr. Dudl. Is there a benefit in having the patients write down the instructions themselves instead of you handing them over to him or her?
Oh, absolutely, if you can get them to do it. And you and I know, I love the engineers who walk in, you know, and they got their pad and they write everything down, and that's just great. So absolutely, you recruit as much as you can from getting the patient to write it down, whatever. So yes, please do that. This was, of course, just an abbreviated presentation.
Great, thank you, Dr. Dudl. Our last question, or it's more of a comment, is to you about, have you heard about the patient literacy education model? The commenters seem to think that this would be a nice complement to this approach.
I would, I'm not sure which of the ones. I've done a fair amount on literacy. I'm not quite sure that I know that particular one. There is it's absolutely essential to be using the literacy model, and thank you for having me come second after the lecture that we just had, or you had last month. But it's really imperative that we deal with the literacy issues, and I didn't touch on them only because of time and because of the last lecture. But if that person in the audience, thank you for that suggestion. I think everyone ought to take a look at it.
Wonderful, thank you.
I wonder if we could take the moment now for folks to type in if there is any one action that they are going to take. That would be very helpful for us to see and to be able to feedback to you folks as to whether or not, you know, is this the right kind of lecture, or should we change it? And, you know, I'm not sure. Let's see.
Again, Dr. Dudl, if you might want to repeat that again, just to make sure that everyone understands your question.
Yes, thank you. If you can go back to your dashboard and back to the questions, if there is any one action that you plan on taking, oh, I heard that, I'm going to try that. I like this idea. I'm going to go after this. If there's one thing that you're going to walk away with that you think you're going to try or do, if you could just type it in to where the questions are, then we can collate that and see if we're on the right direction, feed it back to you, and decide which direction we're going. And, you know, to the others of you, my question box is so small, I'm not getting to the end, so I don't know what the results are of this so far. I see somebody typed in ask, educate, ask. It looks like there are many good ideas coming in. I'm not sure we have to hold everybody. I don't know if I guess we got 2 minutes. But I'm very appreciative. This is a very active audience. I've never had quite so much activity from the audience on a webinar, and it's delightful. Thank you so much. So I'm going to turn it back to you, and you can continue, but I'd love to see all these answers by when they come.
Terrific. Thank you, Dr. Dudl. Absolutely. We will record them and send them over to you, and we'll be sure to take your suggestions for future webinars. Just a couple, again, thank you all very much for attending this webinar. We hope you found it useful. We'll certainly take all of your feedback and, again, make sure that we have some other future webinars that really meet your needs, just like this one I'm sure did. We hope you join us for our next webinar that we will be hosting on May 8th with Dr. Rick Botello on motivating resistant patients. Also, please complete the feedback survey that you will receive in the thank you email from us, especially if you are looking to get a CHED or an ARGI credit for this webinar. Also, I know a few of you had some issues with audio. We apologize for that. This was a GoToWebinar issue. We do, again, have this recorded, and we'll be posting it on SurroundHealth tomorrow, along with the slides and the handout. So you can also, of course, review it again. And again, thank you very much for joining us, and thank you to the National Communication Association for sponsoring us. Hope you have a wonderful rest of your day.